Continuing with our recent advances and recent topics in surgery series, today we will be discussing recent topics in GI surgery. Okay, so we won't be doing the conventional things, intestinal obstruction, malignancies, and so on. We'll be doing things which are a little newer, little more advanced, some new investigations, staplers, and so on. All right. So, as always, if there are any doubts, please feel free to message in the chat box so I know you guys are with me. I can see all your messages there. And as people are joining in, just give me a few moments to tell you a little bit about myself and our platform. Right. So we at Unacademy help you prepare for all the upcoming entrances and including NEET PG. And I am Dr. Amrit Nasta. I am your surgery educator at Unacademy, and I am a bariatric surgeon from Mumbai. There is a free scholarship test which will happen on 10th of July. It's absolutely free. Please go for it. If you get a good rank in this test, you will get amazing offers and scholarships on subscription plans. So go for it. Try your luck. If you are good in pathology slides, make full use of this. If you are planning to subscribe to the Plus platform, there are some offers which are going on for a limited time only. Like if you take a 3-month subscription, you will get 1 month extra free. If you take a 1-year subscription, you get 2 months extra free. So all you have to do is apply my referral code and take any of the subscription plans. You can take a Plus subscription where you have live classes like we are having now, but with a much smaller audience, better interaction. You can get access to the batch courses. There will be a proper schedule for you to study accordingly. And if you take the iconic plan, which is minimum duration of 1 year, you get access to the Plus platform as well as Prep Ladder. Now Prep Ladder has recorded lectures and written notes and so on. But remember, iconic plan is minimum 1 year duration. Also on the Plus platform, there is a feature which is newly launched called Raise a Hand. So you can actually physically, verbally ask your doubts instead of typing everything down. So there are times where you find it difficult to ask your doubt properly. With this, you can ask verbally and the educator can respond to you then and there. There is a good news for MBBS students, like there is a 4-year subscription plan newly launched, and you can take the Plus subscription or the iconic subscription. They are at very reasonable rates, and if you apply my referral code 10surgery, you will get a 10% discount on these subscriptions. So this is really reasonable for 4 years. And since Unacademy has started professional batch courses for first, second, third and final MBBS, even if you are in MBBS, you can make use of these plans. And for FMG, there is a comprehensive course of 6 months duration, which is going to start on 7 July, which you can access on Plus. On next 2022 comprehensive plan course for 6 months, and a short-term course for NEET PG 2021. This is a 2 months course. It will have grand tests and it will cover all the subjects in a brief amount of time to give you a good revision. All this is available on Plus. And of course, limited time iconic subscriptions. There is an offer going on for different durations. All these reduced rates are possible if you use my referral code, that is 10surgery. Okay, so that is about me, that is about our platform. Yes, very good evening to you, Vineet Kumar, and all the others who have joined me online. Any doubts that develop during the class, please message in the chat box, and of course try to answer as many questions as I have lined up for you today. New questions, tricky questions which have not really been asked in GI surgery. Okay, so they are more to do with the recent things, the new changes that are going on maybe in the last 10-15 years. Some new investigation techniques, things which are not very exclusively covered in MCQ books. So we need to have a little idea about them. Not too much, but little. Those who attended yesterday, we discussed things like blood substitutes, hemoglobin substitutes, laparoscopic devices, something like that. Okay, so let's begin. Let's see how you handle today's MCQs. Little challenging, but not over the top, but fairly new. Okay, good evening, Mr. OT assistant also. So this image has never ever been asked. Never, they have never asked this image. So I am just asking you to identify what this image or what investigation is used that is shown in this image. Is it a barium enema? Is it a virtual colonoscopy? Is it an optical colonoscopy? Or is it an EUS colonoscopy? I'm sure you can identify that this looks like the colon. So let us not be under the impression that colon will look absolutely like this. ऐसा नहीं दिखता colon. Human colon is not actually this well shaped. It actually looks like this. So if you are given any colonic imaging, please don't expect it to look like this. It will look like this. What kind of image is this? Datesh and Vineet have quickly gone for virtual colonoscopy. Acha, virtual colonoscopy, 3D reconstruction. But virtual means what? Where does the patient go? Who does this investigation? Is it done by surgeon, gastroenterologist, radiologist? Who does virtual colonoscopy? Because conventional colonoscopy is done by gastroenterologist usually. So who does this? Does the surgeon do this? So this is not barium enema for sure. Barium enema is nothing but an X-ray. It's an X-ray where you will see contrast in the colon. That is barium enema. The contrast is injected perennially into the rectum and as proximally as it goes. Optical colonoscopy करके कुछ नहीं होता. I just created this. EUS colonoscopy. Anybody knows what kind of an image you will get in an EUS colonoscopy? You know EUS, endoscopic ultrasound. Endoscopic ultrasound. So EUS colonoscopy में कैसी image आएगी? And why are you saying this is virtual colonoscopy? So Datesh has said one thing correct. This is virtual colonoscopy. This is done by radiologist. But what? In which machine is this done? Is there a machine to do virtual colonoscopy? How is this done? Means which department in radiology will you go to? X-ray department, fluoroscopy department, ultrasound department, CT, MRI, or there is a special virtual scopy department? ऐसा कुछ होता है क्या? And you see how nice this is looking. Okay, so this is actually nothing but a CT scan. Okay, this is nothing but a CT scan. So when I do CT scan, nowadays CT scans have modules with which they can do what is called as a three-dimensional reconstruction. So what they do is they do CT and then the computer analyzes it and it gives you a picture of the colon, an interior picture of the colonic mucosa also. You have for colonoscopy, you have to do a few extra things to get a heightened image like this, a nice image like this, like you have to inject air. But the air is put perennially into the colon and then the CT scan is done. So the mucosa gets highlighted because otherwise the mucosa would be collapsed. You want the mucosa to become highlighted, but at the end of the day, what is the investigation? It is a CT scan. So any image you see with these nice colors, which looks like a computerized image, which even from inside looks like a normal image, but it is a computerized image, graphics, it will be a virtual image. So like you have virtual colonoscopy, you have virtual esophagoscopy, gastroscopy also. All the scopies can be done virtually like this. Alright, what is the main advantage of virtual colonoscopy compared to conventional colonoscopy, where I actually put the colonoscope inside and see everything from inside? What is the main difference between virtual and conventional or standard colonoscopy? When would I prefer this? So what is the main difference or what is the main advantage of virtual and what is obviously the main disadvantage of virtual compared to conventional? These are the only 2 points that they can ask you. Either they'll give you an image or they'll ask you identify the true statement. Non-invasive, I wouldn't say. An endoscopy also you cannot say is invasive, truly speaking. Like it is minimally invasive, an endoscopy. So the main difference is in colonoscopy you require anesthesia. This requires no anesthesia because this is a CT scan. The person goes in the CT machine, IV contrast is given, end of the story. So no anesthesia is required. What is the main disadvantage of virtual colonoscopy compared to conventional colonoscopy? Disadvantage. Advantage तो बता दिया, no anesthesia required. Yeah, disadvantage, cannot take biopsy, cannot do any intervention, obviously, because the endoscope is not going. So no biopsy, no intervention is possible. Okay, clear? These are very unexplored topics, so you need to have a little idea about them. So you see how it is looking in a normal standard colonoscopy and how it is looking in virtual colonoscopy. So they have done both the tests in the same patient, virtual colonoscopy over here and normal colonoscopy over here. So what you see is the polyp that you saw in virtual is also there in real colonoscopy. So first I do virtual, and if I find something useful, then I may go ahead and do a conventional colonoscopy and take a biopsy. So this is no anesthesia. Yes, you put CO2. It is obviously pain free because it's just a CT scan, but this is the main problem. No intervention is possible. This image that you see, this is an EUS, endoscopic ultrasound. Endoscopic ultrasound, the only thing is it will be a circumferential image. It is an ultrasound only, so it will be a gray image, black and white image, color nahi hoga usme, but it will be circumferential. It has to show you all the layers. I will just zoom in a bit. So what you see here, this is the tip of the endoscope, right? This is the tip of the endoscope, so you know this is endoscopic ultrasound, and you can see the different layers: mucosa, submucosa, muscularis, serosa. So if there is a tumor here, for example, I can identify the depth of invasion of the tumor. This is the main advantage of endoscopic ultrasound. I can get the depth of invasion. Of course, I will do the biopsy, no doubt about it, but I will get the depth of invasion, because biopsy are not going to be full thickness. So it's not always possible to gauge the depth. This will give me depth of invasion. It will show me the regional lymph nodes. Can we diagnose ulcers with virtual? It is difficult. It's not very popular, virtual imaging. Okay, so it is difficult. Best is still the conventional endoscopies. Virtual endoscopies are not very popular. In my whole surgical practice, I must have barely ever used this. But we need to know only for MCQ purposes, because these things can be asked because they are not very explored topics. Okay. Hello Anshika. Let's see if you can handle this one. This is perhaps the most important topic, most important recent topic in GI surgery. Some part of this I had also discussed yesterday. Yesterday we spoke about return to work after lab coli. It's based on this same principle. Good evening Anshika. And I had mentioned this terminology, ERAS. This is very, very new. This has come maybe in the last 10-15 years. Pehle nahi tha ye. Okay. So when I was in my surgical residency, that time this topic for MS graduates, postgraduates, was a VIMP topic. Now it has become important overall for all surgical branches. So I had said this yesterday. Originally, ERAS was introduced for hepatobiliary and colorectal surgeries originally, and then now it has been used for other surgeries also, like other onco surgeries, bariatric surgery, other procedures. So according to ERAS protocol, prior to colonic surgery, so let's say I'm doing a hemicolectomy for a CA colon, patient is allowed to consume clear liquids up to what duration prior to surgery? Okay, up to what duration prior to surgery? So I've gotten two answers over here. Now what you need to understand, in olden days, what they used to do was, olden I mean 10-15 years back, if I am doing any major surgery, I will keep the patient fasting prior to surgery for, it is variable, for 8 to 12 hours. ऐसे करते थे पहले. what we would call as overnight fasting. So if I'm doing a surgery at say 8 in the morning or 9 in the morning, I would tell the patient you can drink water till midnight and then you can't take anything orally. So the problem was the patient has been starving for 8, 10, 12 hours. Now starvation causes a lot of metabolic effects on your body. When you're starving, then your muscle glycogenolysis, all the other stress hormones are produced to keep your sugar levels good. So this was detrimental to the surgical outcome. They said if the patient is fasting so much, the surgical outcome won't be good. He will be dehydrated. He is not going to be physiologically fit. They found complications more. So there were new changes that came. They said, don't keep him fasting for so long. Let him have clear liquids. Now, clear liquids means what? Means he can have liquids like water. He can have liquids like clear coconut water. So you can't have a fruit juice. Okay, that's not a clear liquid. You cannot have chai coffee if it has milk. But yes, he can have clear liquids up to 2 hours prior to surgery. So some of you got the answer correct, some of you wrong. Remy Sinha got it wrong. You can have it up to 2 hours, which means if I am going to do a surgery at 9 a.m., I will tell the patient you can have water till 7 a.m. But this is only for clear liquids. Okay, because clear liquids will get emptied very fast from the stomach. He can have pureed liquids or pureed liquids like milk for 4 hours prior to surgery. Pureed liquids, soups, kind of things. There should be no physical material. It should be strained, but it can be pureed up to 4 hours. And he can have solids 6 to 8 hours prior to surgery. Okay, so I cannot tell him, you have your breakfast and then after 2-3 hours we'll do your surgery. No, that's not done. Breakfast he cannot eat if his surgery is at 9 or 10 in the morning. But yes, he can have liquids up to 2 hours prior to surgery. These are the new guidelines of ERAS protocols which are followed in most of the GI surgeries nowadays. So what is this ERAS? ERAS is enhanced recovery after surgery. Okay, enhanced recovery, it's a very popular topic. It is used it overlaps with many branches. This is not only surgery, it overlaps with anesthesia, it overlaps with medicine also. So what do you do in ERAS? You tell the patient pre-operatively that you get admitted on same day of surgery. So if the surgery is at 9 in the morning, you tell him to get admitted same day. You allow him to take liquids 2 hours prior and you avoid bowel preparation. So nowadays they say even if I'm doing a colonic surgery, bowel preparation does not benefit, because when I give bowel preparation means he has to take laxatives. He takes laxatives, he'll have diarrhea. He'll have diarrhea, he will be dehydrated, and all this affects the outcome. So no bowel preparation. Each of these points is a potential MCQ. So the question will be, all of these are components of ERAS protocols except, and there will be some things like this. During surgery, he should be given short-acting anesthetics, so he's not sedated for a long time. You should avoid putting catheters, drains, Ryle's tube. All those things should be avoided. And post-operatively, he should be mobilized early. Oral feeds should be started early. Yesterday, I was telling you, after lap chole, when do you start oral feeds? I asked this yesterday. After how much time can you start orally? Like if my lap chole got finished at 12 in the afternoon, when can I start drinking water? If any of you has undergone any of these surgeries, you should know. After how much time did the surgeon allow you to drink water? Yes? How much time? These are the really tricky questions that come in our exams, and they do come. And general surgery is a difficult topic. This is core general surgery, which is there in the books. Yeah, after how much time after lap chole can I start drinking water? 4 to 5 hours. Okay, so you don't have to keep him starving after surgery for 1 day, 2 days, 3 days. Not required anymore. Surgery is finished at 12. Tell him you can start having water from 5 in the evening. No problem. And discharge them early. Don't keep them in the hospital unnecessarily. I am telling you, each of these points they will make an MCQ. ERAS protocols. They are called ERAS protocols, and all this is there in Bailey. Okay, all right. This again is a question they have never asked. And this disease or this topic has also regained popularity maybe in the last 10 years. This was unknown for a very long time, but now a lot of general surgeons know this. So this procedure, stapled transanal rectal resection or STAR procedure, is done for which of these diseases? So this STAR procedure became very popular when I was doing MS. It was still very inceptional, but then it gained a lot of popularity. And now again, it has become, there has been a little dip in this, but all general surgeons know about this. So the person setting your paper for INICET, he may be knowing this. And in Bailey, there is barely 4 or 5 lines mentioned, which I will show you what lines are mentioned about this. Okay, so let me see. Anybody? Somebody? Nobody? Is it so difficult? That is the idea. You should know the difficult things now, when it's close to the exams. I don't know when NEET PG is going to be, but INICET के लिए तो ये आना ही चाहिए, because this is high level for INICET. This is not NEET PG. NEET PG, they don't ask such tough questions. Yes, Rimi, Datesh. Rimi has gone and Koyal Kundu has arrived. OT assistant Ashish, all of you have gone for ODS, obstructive defecation syndrome. Okay, that is a strange one. What is the other name for obstructive defecation syndrome as per Bailey? Anybody knows other name? Alright, while you try to answer that, let me help you how to analyze a question like this, because 90% of you would not have even heard of this procedure or of these diseases, but these are not unsolvable questions. These are not questions you should leave, because the issue is when I make a question like this, it's difficult to put options. It's difficult to put close options. Okay, close options are difficult. Now, stapled means you are using a stapler. Transanal means you are going through the anus. What are they doing? They are doing a rectal resection. So, what is the surgery doing? In this surgery, I am doing a resection of rectum. Resection of rectum means, okay, let's say this is sigmoid, this is rectum, this is the anorectal sphincter, this is the anal canal. What am I doing in this? It is saying resection of rectum means for whatever reason, I don't know the reason, I am going to resect some amount of rectum. That's what it is saying, rectal resection. I have given you the full form. Now, see the options, even if you can't make out the answer. Hemorrhoids. Where do you have hemorrhoids? Hemorrhoids are seen where? In what part? In this picture, where would you get hemorrhoids? Similarly, where would you get anal fistula? And of course, pilonidal sinus has nothing to do with rectum. Okay, nothing with rectum. Pilonidal sinus is a skin problem, skin and subcute. It is at the upper part of the natal cleft on the back side. It's a dermatological problem. The hair grows, creates a sinus into the skin. It's a skin sinus. So of course, in a pilonidal sinus, I am not going to do any rectal resection. Out of the question. This option should be eliminated first. Where do you see hemorrhoids? Hemorrhoids are seen in the anal canal. Correct. यहाँ पे होती है dentate line. The hemorrhoids, they start as venous dilations above the dentate line and then they start getting pulled down. उसमें मैं rectum क्यों resect करूँगा? No question. Anal fistula, again anal canal. So both these options can be easily eliminated. So the only option left in this case, so if you would have left this question saying मैंने कभी star procedure सुना नहीं है, it would have been a disaster. It would have been your loss. If you apply common sense, you can eliminate the option. Then you can say, okay, so probably it is done for this disease, ODS, obstructive defecation syndrome. And that is the correct answer. Nobody told me the other name for ODS. What is this disease? Obstructive defecation syndrome. You don't need to know too much about it, you need to know a little bit about it. In obstructive defecation syndrome, it's a unique disease, one of a kind. In this disease, there is a rectal intussusception. So the rectum intussuscepts in itself, and this causes sort of a obstruction, and that leads to constipation. Okay, it is seen probably in people who have poor bowel habits, where a part of the rectum intussuscepts into the distal rectum. Maybe it intussuscepts into the anal canal, but definitely there is an intussusception. And where there is an intussusception, there will be constipation, like an intestinal obstruction. That's why it is called obstructive defecation. So the presentation is chronic constipation. It is one of the causes of chronic constipation. So what do I do in this? I use a stapler to resect the intussusception. So जो intussuscepted rectum है, I excise it with the help of a stapler. Which stapler will I use for doing this? I resect the intussusception. So this gets resected and the rectorectal anastomosis is done. Which stapler will I use to perform star? This you must know. There is no escaping this. कौन सी stapler say I will do resection of rectum and anastomosis? I can't give you choices for this. If you want, I'll give you, but really speaking, you don't need choices for this. Nobody? Anybody? My God. Anshika, OT assistant, Vineet Kumar, Koyal, Ashish, Tatesh. Nobody? Somebody? Okay, so it looks like this. This is the stapler that is used, and this part of the stapler is called the anvil of the stapler. So जहाँ पर intussusception होता है, उसके across I will put the anvil of the stapler, take the rest of the stapler and resect it. This is called a circular stapler. Okay, this is called a circular stapler. Other name for obstructive defecation is called SRUS, solitary rectal ulcer syndrome. Solitary rectal ulcer syndrome. Okay, now how do I diagnose this intussusception? The investigation of choice is MRI. It's called MR defecogram. So what is done is a contrast is given per rectally, and the person is told to attempt to strain, and when he's straining, the MRI is done. That's why it's called defecogram. So when he tries to strain, the intussusception gets manifested. So investigation of choice, MR defecogram. This is all you need to know about it. That it is a intussusception. It presents with constipation. It is diagnosed on MRI, and the treatment, one of the treatments is STAR procedure, staple transanal resection of rectum. Which stapler do I use in the staple transanal resection? Circular stapler. Okay. What is this procedure that is happening using a circular stapler? Anybody can make this image out? Can you identify the procedure that is happening in this image? You want choices for this? I will give you choices for this. What procedure is happening? I hope the answer comes before my choices are mentioned. This procedure that is being done here. Either it is PATME, or is it VAAFT, or is it a hemorrhoidopexy? Yes, so this, what you see, these are the pile masses. They are also being stapled. So this is a hemorrhoidopexy with staplers. The same stapler is used, circular stapler. Okay, so circular stapler can be used for rectal disorders, anal disorders like hemorrhoids, and for obstructive defecation. These are the two disorders where I use staplers for anorectal disorders. Okay, let's move on. This question is also very new, but this I have discussed in some of my special classes before. So I'm guessing quite a few of you must have heard of this because ये मैंने पहले discuss किया है. But again, this is very new. Patient undergoes implantation of something called as a Bravo capsule in his esophagus. What is the use of this device? Bravo capsule. This is also very new, and this is not there in Bailey. This I just know because I have seen it in use and gastroenterologists know about it. So what is the use of Bravo capsule and what is its common counterpart? इसका एक common counterpart भी है which you must have heard. So I got some answers as B, C and D. Nobody for A, nobody for obscure GI bleed. Yeah. And what is its counterpart? The commonly known counterpart of Bravo capsule. So two things. First things first, this is put in his esophagus. That should give you a clue. Like a helpful person, I have written over here implantation of Bravo capsule in his esophagus. I never said implantation of Bravo capsule and then you figure out where it has gone. And I said implantation. He is not swallowed it. Okay, it has been implanted. So it is in the esophagus. If it's in the esophagus, it can't be for obscure GI bleed. This is out. None of you marked this. For pressure studies, what we do is called a manometry. No capsule is put. You do esophageal manometry. How do you diagnose esophagitis of eosinophilia or eosinophilic esophagitis? How is this diagnosed? Yeah, some of you have given the correct answer. Good job. How do you diagnose eosinophilic esophagitis? Investigation of choice. Don't say barium swallow showing herringbone pattern. That is not how you diagnose it. आज के ज़माने में barium swallow is not a diagnostic test for anything. You do endoscopy with esophageal biopsy. That's right. So Gagan Arora has given the correct answer. It is endoscopy with biopsy. Endoscopy will be normal. You have to take blind biopsies of the esophagus and on histopath you get the diagnosis. This Bravo capsule is for correlation of GERD symptoms and its counterpart, it is similar to 24-hour pH study. 24-hour pH study. It is quite similar to 24-hour pH study. Now when I do 24-hour pH study, what I have to do is I have to put a catheter from the nose which goes all the way into the GE junction and it has a recording device and the patient has to keep the catheter for 24 hours. So he goes home, whenever he feels the reflux symptoms, he presses the button, it all gets recorded and the pH gets recorded. So when I do 24-hour pH study, the catheter has to be there, which is a little uncomfortable. So there is a new device called Bravo capsule. Now what is Bravo capsule? It is different. Principle is the same, but the device is different. I'll tell you. So this device, instead of putting a catheter, endoscopically, I put this device at the lower esophagus. It's a capsule which gets stuck at the lower esophagus. Okay, that is the meaning of implantation at the GE junction. And it works same like the 24-hour pH catheter. It will record the pH values and the person wears that portable recorder and when he feels the symptoms, he presses the button. All that is the same. Only thing is this has to be implanted. It's not like a catheter, but the advantage is once it is inside, it's inside. Patient does not have anything in his nose. So there is no catheter required. And this device, this Bravo capsule, will remain in the esophagus for about 48 hours. After 48 hours, the capsule gets dissolved, the coating gets dissolved, it goes into the stomach and then it gets digested and is passed in the stool. Like capsule endoscopy, something like that. So this will give you a recording of 48 hours or maybe even longer as long as it is there. and the person does not have to wear any catheter. This is the main advantage. So it's very comfortable for the patient. In 24-hour pH study, he has to keep the catheter. उसमें क्या होता है? The catheter goes from the nose into the esophagus and it records the esophageal pH levels at different sites, which gets recorded on this graph. Have a good look at this graph also. ये graph भी पूछा नहीं इन लोगों ने. How do you identify this? It's very one of a kind graph. The way to identify a graph like this, which you may have never seen, just look at the gradation. Look at the calibration. What you see here, these are times. This is time. 11 a.m., maybe 6 p.m., 9 a.m., 11 a.m. So all these are times. And what you see here, 0, 0.5, 1, 1.5, so on, up all the way till 8.5, the word written next to it is pH. So this graph is telling me pH values across different time. That's why it is 24-hour pH study. Okay, absolutely clear. This graph also they have not asked, so you need to know a little bit about it just to identify. I really doubt they will give you a graph and tell you what is the disease. वो तो नहीं देंगे. अगर दे भी दिया, you know it will be GERD. Because this is 24-hour pH study, so it will be used to diagnose GERD. That much also you will know. और कुछ use नहीं है 24-hour pH study का. Don't worry about it. This is the only use of this. But new thing, Bravo capsule. Okay, it can give you pH values for 48 hours. No need for catheter. The capsule is put endoscopically at the GE junction. It does the recording, and after 48 hours or so, it gets dissolved and it is passed in stool. End of the story. Okay, great. All right, this also is an IMP image. This is not really a new topic. This is a very unexplored topic. Okay, it's a very unexplored topic. So a female presents with abdominal distension. Some CT findings are given and a laparotomy is done. Then you see these things on laparotomy. What is the person having? The reason I put this image is there is a similar image in Bailey. Not the same one, similar image. And the topic is very important. It's one of a kind. And it's very virgin. They have not asked it too many times, and there are a lot of potential MCQs. It's just a one paragraph topic in Bailey, but too many MCQs can be asked from this. Vineet Kumar and Saif Shah have picked something. Mucinous cyst adenocarcinoma of ovary. Excellent. So what you see here, even if there was no CT description, if they had straight away given you the laparotomy picture, the answer here is Pseudomyxoma, peritonei, PMP. How does miliary TB look? Let's say I ask you, why are you saying it is not miliary TB? How will miliary TB look? Miliary TB can also be seen on laparotomy, a sort of like this. How will that look? Why is this not miliary TB? Forget the CT findings. The CT findings are quite similar in both. Omental caking can be seen in both. So just because I said it's a virgin topic, you went for PMP, or there was something that told you this is PMP and not miliary TB? So in miliary TB, you will see tubercles, but the tubercles will not be bunched like this. They will be discrete tubercles. Yes, there will be multiple tubercles, but they will not be bundled like this. They will be discrete all over. Okay, all over. बहुत सारे छोटे tubercles you will see, but they will be fairly discrete. What you see here, these are jelly-like cysts. Yeah, millets, absolutely right. What you see here, these are jelly-like cysts. Jelly-like cyst means it is Pseudomyxoma peritonei. Okay, classic intraoperative image. Hydatid, you know how it looks. It is that white fluid-filled sac. It will be white, fluid-filled. You must have seen hydatid, I'm sure. It will have scoliosis, it will have sand, all those things. Daughter cysts. This is not highlighted. What is gossypioma? What is this terminology, gossypioma? This also they have not asked. How does gossypioma look? What is the meaning of gossypioma? And while you answer that, also tell me what is the treatment of PMP. इसका मुझे treatment भी बताओ. Organ in the image. This is peritoneum, na? This is probably peritoneum. So it's on the peritoneum and abdominal wall, the parietal peritoneum. Probably it is that. So it's not an organ. It is the anterior abdominal wall, the parietal peritoneum. That's what it looks to me. Gossypioma. Cotton. No, it's not cotton. I think you are thinking too much biology. This is not biology, but I appreciate your efforts. Gossypioma means left foreign body, or a foreign body which was left behind. What foreign body was left behind? Gospies, mops. So sometimes what happens, you do a laparotomy for, let's say, a perforation, and everything is done, and at the end the surgeon is tired, the nurses are tired, it was a long surgery, and by mistake something is forgotten, like a gauze or a mop. Now if it is left behind and not identified at that time, and you close the abdomen, nothing happens at that point of time, but maybe few weeks or months or years later, that foreign body will cause reactions, adhesions, fibrosis, and patient can have future complications like maybe intestinal obstruction. It's possible. So when there is intestinal obstruction, you will do a CT scan, and the CT scan will show a foreign body which is called a gossypioma, and when you do surgery for that, you remove the foreign body and the obstruction gets relieved. So what is gossypioma? It is a leftover foreign body. It is unintentionally leftover. It's not like a mesh for hernia. Varna you will say mesh implant. Those are intentionally left behind. Those are therapeutic. Those are not technically foreign bodies. This is an unintentionally forgotten foreign body, like a gauze or a mop. Yeah, I think it means to forget cotton at the time. Okay, fair enough. And Vineet has said treatment of PMP, cytoreductive surgery plus high temperature, some chemotherapy. Excellent. Excellent answer. Sugar Baker technique. So every point in this you need to know. This entire slide, every point is MCQ worthy. Yeah, high pec. Absolutely right. It's called high pec. So high pec bhi bolte, pi pec bhi bolte. Every point you need to know in this. So Pseudomyxoma peritonei, it is believed to be a dissemination of an ovarian or an appendicular neoplasm, cystic neoplasm. Someone answered this earlier also. Mucinous adenocarcinoma, that's what Vineet said. So a mucinous tumor, probably of the ovary or appendix, one of the two. Which is why, since it is believed to come from ovary, more common in women, goes hand in hand. What do you get? Throughout the peritoneal cavity, which means peritoneum on the abdominal wall, peritoneum of the viscera, liver, spleen, small bowel, colon, stomach, सारे peritoneum के ऊपर you get these jelly-like cysts. ऐसे. It is believed to be tumor metastasis, believed to be, but they don't really know the origin. And because of these jelly-like cysts, the patient presents with abdominal distension. Not so much of the primary malignancy, but because of these PMPs. There is only one treatment. It's a very major surgery. Very few oncosurgeons do it. So the surgery is called cytoreduction. Cyto means tumor reduction basically. And what do? It is called Sugar Baker technique. ये नाम मालूम होना चाहिए. Sugar Baker technique. This has become very popular. Huh? This surgeon is still alive and he takes lectures on cytoreductive surgery. So you need to know these are contemporary surgeries and contemporary surgeons. So what they do is, ये लिखा है इधर सिर्फ, they remove a lot of peritoneal linings. So they remove the peritoneum of the abdominal wall, they remove the omentum, If possible, if required, they may remove the stomach and do an anastomosis. They may remove some parts of colon, gallbladder, spleen. Wherever they see the tumor, they remove it. So it is a major surgery. It goes on for several hours. Lot of things have to be excised. And after the surgery, intraoperatively, they give chemotherapy. This is called HIPEC. HIPEC is heated or hyperthermic intraperitoneal chemotherapy. Okay, heated, so it is at a certain temperature, 40-42 degrees. So you take mitomycin C solution, it has to be heated a little bit, and that is instilled in the peritoneal cavity. It is left there for some time and then it is drained out. So it works like a contact chemotherapy, sort of. It is like a contact chemotherapy, but it is at the same time as the surgery. So it is cytoreductive surgery with HIPEC. Okay, it is with HIPEC. HIPEC is hyperthermic or heated intraperitoneal chemotherapy. ओके ये सब वर्ड्स नहीं पूछे. हाइपेक भी होता है, एक पाइपेक होता है. पाइपेक इज प्रेशराइज्ड इंट्रापेरिटोनियल कीमोथेरेपी. ठीक है. ओके, this is my predicted image. I predict an image like this will come and a question will come on this topic. ये टॉपिक पे क्वेश्चन आने वाला है because this has become too important nowadays. A little too important. A lot of research going on this topic. So to perform this test, what sample is taken? So I have, this question goes in multiple steps. First you need to identify this test. It's a slide, and in the slide something is done, and to do the test, first you need to know what is the test for, what is the organism. Yeah, absolutely right. So this CLO test, or if you read carefully, यहाँ पे लिखा है rapid urease test, RUT. It is done to diagnose H. pylori infection. Now what sample do I put on this? Most of you answered breath. My dear boys, how will I put breath on this? Of course it's not breath, this is gastric mucosa. Okay, this is not urease breath test, this is rapid urease test, not breath test, unfortunately. No, this is a slide. On the slide I cannot put his breath, but what can I put? So I do first an endoscopy, and during the endoscopy I take a biopsy of the gastric mucosa, usually from the antrum. And that mucosal antral biopsy, that piece of mucosa that I get, I put it on the slide. Originally the slide is yellow. If it remains yellow, the test is negative. If it turns red or pink, the test is positive. Okay, so to perform this rapid urease test, the sample is mucosa of the stomach. It is not breath. Breath is going to be put in a machine to diagnose rapid urease activity or urease activity. This is far more sensitive to diagnose H. pylori. Rather specific. I won't use the word sensitive, I'll say specific. So when I talk about H. pylori, the important things that you need to know, the first and foremost is it not only causes antral gastritis or antral ulcers, it is also causing duodenal ulcers. Dono. No, stool sample will not give rapid urease test commonly. No, gastric mucosa will be the answer. Stool में you may get H. pylori, but nobody does it. आज के ज़माने में कोई नहीं करता. You get antral ulcers, you get duodenal ulcers, and it is a pre-malignant condition. It is a pre-malignant condition. It can cause stomach cancer, adenocarcinoma, and malt lymphoma. It is a class 1 WHO class 1 carcinogen. Okay, it is a class 1 carcinogen. I already told you how it is diagnosed: RUT test or rapid urease test or CLO test. CLO is Campylobacter like organism, and the sample for that is endoscopic gastric mucosa, mucosal biopsy. Treatment, you know, 3-drug, 4-drug regimen, they must have taught you in pharmacology. That's fine. Surgical implications are these. No, why would you do gastric lavage? Gastric lavage में mucosa नहीं आया. And how will you put the gastric lavage sample on the slide? This is how you're going to do it. Don't do lavage. Why complicate it? This is much easier and much more commonly done. This is done day in, day out. The person who will set your question will be doing this, so he knows about it. All general surgeons know this. All general surgeons. Okay. When I say rapid, how much time does it take for the color to change? Usually the color change can be observed in 10 to 15 minutes. But to say the test is negative, before I give a negative report that no color change has happened, to give a negative report, I wait for 24 hours. These are the two numbers you need to know. Why is it rapid? Because if there is H. pylori in the mucosa, the urease activity will change the color within minutes. That's why it's called rapid. But that does not mean अगर 10-15 मिनट में color change नहीं हुआ, you say test is negative. No. To label the test as negative, it should remain yellow for 24 hours. Okay. Only then you say test is negative, because sometimes it may take a little time for the urease activity to manifest. It may take a few hours, but usually it is rapid. Okay. OT assistant wanted some points. You can note down all these points about H. pylori and how it is diagnosed. Again, this is a VIMP topic, and the slide I will show you after this is VVIMP, and all the values are from Bailey. When I am doing a esophagectomy for CA esophagus, what should be the proximal and distal resection margin for oncosurgical clearance? So if there is a CA esophagus, let's say middle part, mid esophagus, how much esophagus should I resect proximally? How much esophagus should I resect distally? 5-5, 10-5, 10-10, 5-2. Let's see what you think. Whatever questions I am discussing today, please have a good look at them. They are not very conventional questions. You may find some things little new, little out of the way. पर अगर इसमें से कुछ आया तो बहुत लोगों को इसके आंसर नहीं आएंगे. Okay, बहुत लोगों को नहीं आएंगे. I am very happy. Most of you have answered correctly. 10 centimeters proximal and 5 centimeters distal. Proximally, it will be 10 centimeters. Distally, it will either be 5 centimeters, or let's say it's a lower C esophagus. Let's say lower C esophagus. Then how much will you go distally? तब तो proximally 10 centimeter जा सकते हो. पर अगर नीचे है, not mid esophagus, if it's lower esophagus, G junction, then how much will you go distally? What about this? इसमें आंसर नहीं मिलेगा उसका. So you go distally 5 centimeters, or you go distally how much if it is at the G junction or lower esophagus, adenocarcinoma. They will not give you this choice then. 5 centimeter नहीं देंगे. They'll give something else, and that will be the answer. In that case, you will resect the fundus. Then the distal margin is the gastric fundus. Okay? So proximally 10, distally 5. If I am resecting for CA stomach, A small bowel, large bowel, B esophagus, D rectum. No, not entirely correct. I accept some things that you have said, but some things are not. Let's go one step at a time. Tell me, if it's a CA stomach, what will be the resection? Let's see what Raksha has to say. Sir, in breast carcinoma, what should be the margin? Gross margin, if you are doing wide excision, is 1 centimeter, but that is gross margin. 1 millimeter is microscopic margin. If they tell you margin in breast cancer in wide excision, it is 1 centimeter. 1 millimeter you can't see with the naked eye, no. You can't say this is the tumor, I'll go only 1 millimeter around it. वो breast में नहीं कर सकते हैं, वो Mohs micrographic surgery में कर सकते हैं. Mohs excision you can do 1 millimeter, but not in a gross surgery. Or stomach 5 centimeter, proximal or distal, or both. I think Raksha said A is small and large bowel. She never said anything about stomach. What is practically done? 1 centimeter. That's what I'm saying for wide excision. 1 centimeter or more. Raksha is saying Borman type 1 EMR 5 centimeters, margins, rest varies. Okay. Too complicated. I'll give you simple, very simple way that you will remember it forever. Okay, extremely easy way I will give you to remember for CA stomach. CA stomach can happen at two sites. Either it will be here in the lower part, pre-pyloric, or it will be anywhere else in the body, fundus, anywhere else. If it is in the antrum, then what do? Then you do a subtotal gastrectomy or a distal gastrectomy. Subtotal or distal. Oncosurgically it is called subtotal. Means you resect proximally at least 5 centimeters or more. Distally it is up to D1, first part of duodenum. So for distal CA stomach, you do subtotal gastrectomy. What will you do for proximal CA stomach? It's over here in the fundus. Then what are your resection margins? Because Raksha said some Borman type 1 EMR 5 centimeter, rest varies, too complicated. You will get confused. They will give you some googly and you will make a blunder in that. If it's proximal CA stomach, how much will you remove? 5 and 5, 10 and 5, what? So they will never ask you a question like this. If it's proximal CA stomach, what you are going to do is called a total gastrectomy. Just remember this much. Total means pura stomach. No point in leaving behind the antrum if you have removed the whole stomach, as Pooja has correctly said. Okay, so for stomach it is this. For small bowel, now different books give different answers. It is this. This is for small bowel. And to some extent, this is acceptable for rectum, acceptable. Okay, I will show you in the next slide the exact numbers. What should be the resection margin for colon? I'll come to the next slide. I'll come on the next page, because Raksha said something for colon also. 5 centimeter A, C, D something. For colon, what should be the resection margin? Yeah. So let's say I have a carcinoma of ascending colon. Just out of curiosity, since you raised the topic, I have carcinoma of ascending colon. What should be the resection margins? यहाँ पर ascending colon, cecum के ऊपर. Siddharth is saying 5 आगे 5 पीछे, 5 and 5. Anyone with a different answer? We have to be smart. We have to be one step ahead. If I am asking you a question like this, definitely there is some trickery. Most of you have been with me for at least the last 5-6 months. So you should know when I am playing a trick on your mind. Yeah. Yes. So for colon, there are no measurements. Yeah, absolutely right. Raksha has given the correct answer. There are no measurements. You do anatomical resection. Anatomical means it is based on the vascularity. If it is cecum ascending colon, I will do a right hemicolectomy. Right hemicolectomy means ileocolic branch, right colic branch, and middle colic ka right branch of middle colic. Right hemicolectomy. There is no measurement. जितना उसमें सप्लाई जाएगा उतना I will resect. If it's transverse colon, I will do extended right. Means I will also take the full middle colic artery coverage. And similarly, for descending colon, sigmoid, I do left colectomies. For rectum, I do anterior resection. Okay? So don't try to remember too many numbers for too many cancers. Your life will become a mess. Let's not do that. So esophagus I already gave you 10 and 5. For stomach it is 5 proximally and distally it is D1. It depends whether it's proximal stomach or distal stomach, but distally it is always still D1. So either you do a subtotal gastrectomy or a distal gastrectomy or a total gastrectomy. It is always still D1. You are not going to leave the antrum behind. Small bowel 5 and 5. Now rectum proximal is 5. Distal is variable. Huh? This is what is given in Bailey. It varies. Or if they ask you 1, then go for 1 centimeter. Don't say 2 centimeters. If they ask you distal margin and rectal cancer, say 1 centimeter. It's the best answer to give. And for colon, I told you, it is based on the anatomy. For splenic, left colectomy, left hemicolectomy. Just one extra point. If I have a gist, then what are the resection margins? I have not put it in this list. Gist hai, like a gist of the small bowel. Then how much small bowel proximal and distal margins do I need to take? For gist. ये नहीं पूछा है. Rectum resections are confusing. Why are they confusing? There are only 2 resections in the rectum. Anterior resection and APR. In anterior resection, you go 5 centimeters proximal, 1 centimeter distal, and do anastomosis. In APR, distally you go all the way till the anal canal, and proximally 5 centimeters. Fundamental is the same. Why are they confusing? Yeah, anybody? What is the resection margin for gist? Gastrointestinal stromal tumor. Let's say the person has a gist in the small bowel. How much small bowel will you resect? Or a gist in the colon. How much colon will you resect? Colon में normally होते नहीं है. Normally gist are seen in stomach or small bowel. Yes, anybody? Raksha, Ritesh. यहाँ पर है patient को just resect till mobile part. Small bowel तो mobile ही है यार. The whole small bowel is mobile. I have to do some kind of a resection. Do I go 5 and 5, 4 and 4, 2 and 2, 1 and 1? How much? No, there is an answer to this. You do a 2 centimeter margin. Yes, Saif, that is correct. So in gist, the resection margin is 2 centimeters. And in gist, I don't go till the root of the mesentery. Okay, when I resect for gist, I am only resecting around. I don't have to go all the way till the root of the mesentery, because I don't have to do any lymphadenectomy. No lymphadenectomy, so no need to go all the way till the root of the mesentery. Please give algorithm for treatment of external hemorrhoids or internal hemorrhoids. External hemorrhoids करके कुछ नहीं होता. Internal hemorrhoids होते हैं. Okay, this question I have discussed before, and a similar question was asked in FMG. अभी जो हुई थी 2 weeks back. In FMG, it was an image-based question. Vineet, I will answer your question. Just remind me in the end. Okay, there are a few more questions to do. Once we finish them, then you remind me this question. Then I'll tell you. Very easy. But it's for I have for internal hemorrhoids, not external hemorrhoids. उसका आंसर मुझे पता है. So there is a young male who has history of abdominal pain, early satiety. He has a mass. CT is showing something. It is a high-grade adenocarcinoma. What is the Borman type? Yeah, so the answer here, what is CT showing? CT is showing diffuse infiltration of the stomach. So diffuse infiltration of the stomach, high grade, of course, is going to be Linitis plastica. And Linitis plastica is grade 4 or Borman 4. In FMG, they had given the image of the different gastric cancers, and they had asked you which classification is used, and the answer probably was Borman type. Which is the other classification for CA stomach on gross appearance apart from Borman? So there is Borman, which is the other type. There are two gross classifications for CA stomach. Which is the other one? So there is one which is Borman, and the other one is which, and how are they different? Yeah, all of you have given the correct answer, almost all of you. Lauren, no, safe. It's not Lauren. Lauren is microscopic. Borman is gross. Lauren is microscopic classification. This is Japanese. How are they different? Lauren is microscopic classification. It classifies CA stomach into intestinal type and diffuse type. Japanese, Paris. I don't know any Paris. I know Japanese and Borman, but how are they different? Japanese is classification of gross types of early gastric cancer, and Borman is gross types of advanced gastric cancer. What is early? What is advanced? Early और advanced में फर्क क्या है? बताओ जल्दी बताओ. Japanese, no. Those are lymphadenectomies, not gross classifications of CA stomach. आप कुछ और ये बता रहे हो पूजा. It's not the same. So CA stomach can be categorized into early CA stomach or advanced CA stomach. Early is Japanese, advanced is Borman, which has these 5 types, and the difference between Borman versus Japanese is in Japanese there is no muscularis invasion. That's why it's early. It is no muscularis invasion. That's why it's early. In Borman, they are all muscle invasive. You see the images, you will understand what I'm saying. They are all muscle invasive. So it will be fungating but muscle. This is the muscularis layer invaded. It will be ulcerating. It will be ulcer with wall invasion, or it will be linitis. But they will all be invading the muscularis or deeper. That is why it is Borman. Okay? No, not TNM based also. Now this question you have to answer in a combination, like you have to tell me which all are the correct choices. That's why I've written 1 2 3 4. So your answer can be 1 2 or 2 3 3 4 1 2 3 1 2 3 4. Whatever is the correct combination, you have to tell that. This is a PGI type of question, and you are going to get 20% questions will be PGI type in INI-CET. So you have to give combination. You can't say one of these is correct. Okay. So a patient with CA stomach in the body of the stomach is planned for total gastrectomy. So I told you, if the tumor is in the body, you are going to do total gastrectomy and D2 lymphadenectomy, which Pooja was saying, Japanese lymphadenectomy. So which of these structures are going to be removed? Yes, Asha, you can change your answer, no problem. You can rewrite your answer. Saif is saying 1 2 4. Datish Siddhartha saying 1 2 3. And I think Asha is saying, I believe she went 1 and 3. And Kaustubh is saying 2 3 4. Amazing. And Abdul is saying 3 and 4. Okay. So there is a tumor here. Greater omentum is over here. Everybody knows what is greater omentum, and lesser omentum is over here. And then you have your lymph nodes. You have lymph nodes along the blood vessels. Last station is going to be celiac. यहाँ पे abdominal aorta होती है. उसमें सबसे ऊपर होती है celiac, जिसमें से it gives left gastric, it gives the splenic artery, all those things. Correct? Okay, अभी depends तो है नहीं ना, there is no depends. All of these structures will be removed. That is the question. They have not given you any scenario. All of these will be removed. Means what? Are you going to remove all of them or not? So let's be very clear. For any kind of gastrectomy, for malignancy, and this is given clearly in Bailey. Don't trust me, you can open Bailey and see. You will remove both greater and lesser omentum. Goes without saying. So greater and lesser omentum to nikalna hi hai if you are doing a malignant resection for CA stomach. Now when I do D2 lymphadenectomy, in D2 lymphadenectomy, I also remove celiac nodes. Celiac station is 8. Are you sure? Celiac is 8. I don't think it is 8. I think you are making a mistake in the number. Celiac is not 8. Spleen is usually not removed. So the answer here is 1, 2 and 3. Usually spleen is not removed unless it is involved in the tumor or the tumor lymphatics. So if they are saying will be removed, then spleen should not be one of the statements. Spleen may be removed, and this is clearly given in Bailey. Maybe. So if you are given multiple, you will not go for spleen. Now what is D2 lymphadenectomy? Let's go step by step. This is an important slide. Okay, each of these you should know. When I am doing a D1 lymphadenectomy, I am removing lymph nodes only in the vicinity of the stomach. It's not commonly practiced. They are called perigastric nodes, 1 to 6. When I do D2, I go all the way up to the major vessels. So left gastric is 7, common hepatic is 8, celiac is 9, splenic is 10, 11. So I am removing all of these lymph nodes also. So when I say D2 lymphadenectomy, please understand in D2, I am not removing 7 to 11. I am removing 1 to 11. Okay, let's be very clear. In the exam, if they ask you, do I remove perigastric? Of course, first I will remove perigastric. Then I will go to the higher nodes. So don't be under the misconception that D2 is 7 to 11. No, D2 is D1 plus 7 to 11. Okay, D1 plus 7 to 11 is D2. This is what is commonly performed. D3, where you remove other nodes, not performed commonly. This may be performed in Japanese because they do more radical CA stomach excisions. But in exam, they will not expect you to know D3. At least they should not. D2 you should know. Very popular topic. And again, this is a question which I am predicting will come. My prediction, this is from Bailey. They have never asked this. Splenic nodes will be removed. Spleen is not removed. All these stations are removed. So in D2 station 10 will be removed, but spleen will not be removed. Splenic nodes will be removed. Nodes along the splenic artery will be removed. Okay. So lymphadenectomy talks about lymph nodes which are excised, not structures which are excised. Celiac artery is not going to be excised. Lymph nodes along celiac artery will be excised. Okay. The last question spoke about spleen being removed. Spleen is not. Splenic nodes are removed, which are along the splenic vein and the splenic artery. All those structures will be removed. Okay. Fulminant ulcerative colitis is characterized by which of these findings? This is my prediction. They have never asked this. And this is there in Bailey. True love criteria. It's not named anything. At least I don't know the name of the criteria. Maybe it is taught by gastroenterologists or physicians. मुझे criteria का नाम नहीं मालूम. But I know mild, moderate, severe fulminant colitis. And there are numbers for each, which you need to know. Yes, बोलो, जल्दी बोलो. एक दो सवाल ही है और not much left. Don't worry. We have gone on longer today than I expected. We've already gone for 1 hour 15 minutes. So let's try to finish. and then I will solve one of the students had some hemorrhoids ka question. I will solve that also. Okay. Japanese guidelines on CA stomach station 10 not removed in distal gastric cancer. Okay, I doubt that will come in your question, because the person setting your paper will not refer to Japanese guidelines. He will be making questions from Bailey, and it just becomes more sensible to remember it like this. My face is paused. I hope my voice is not paused. Yeah, the face is paused, but the arrow is going on. I don't know why. Okay, we will continue. Don't worry. Keep it going. So fulminant ulcerative colitis is characterized by, answer is not 5, it's not 15, answer is 10 stools per day. I don't know why the face is paused. I didn't do anything. And these are the numbers you need to know. Mild will be less than 4 stools, moderate is 4 to 6, severe is more than 6 stools per day with hypoalbuminemia, which I gave in the option, and fulminant is more than 10 per day, or toxic megacolon. If they won't give you toxic megacolon, because of course you will understand toxic megacolon is going to be fulminant. So they will give you stools ke numbers. So these are the numbers you need to know. Okay. About treatment of hemorrhoids. I don't know why the face is paused. About treatment of hemorrhoids, a simple way to go about is, if it is grade 1, grade 2 hemorrhoids, you will do minimal procedures. And minimal procedures here imply either you will do banding or you will do sclerotherapy. If it's grade 3, you can do stapled procedures, stapled hemorrhoidopexy, or you can do open hemorrhoidectomy. And if it's grade 4, you will do open hemorrhoidectomy. Mind you, these are going to be done, minimal procedures, only if the patient is having symptoms and lifestyle modifications fail. Otherwise, even these are not required. But for MCQ purposes, go with these. Grade 1, grade 2 with symptoms, go for banding or sclerotherapy. Grade 3, any of these can be done. And for grade 4, you will do open hemorrhoidectomy. Okay. My next class, I will be taking a special class tomorrow evening, mostly at 7 o'clock. And tomorrow I will be doing a special class on PYQs. Okay, mostly I will keep it around 7 o'clock. If there were any issues you faced in the class except for my face getting paused, you can report on the bugs bounty. And if you enjoyed this class, do remember to give it a thumbs up and like this video. And Datesh, whatever you want, please message me on Telegram. I'll share it, not on the group, but I can give it to you personally, no problem. This is my Telegram link. All right. This is my referral code if you are planning to subscribe, and I will see you guys tomorrow in the special class on PYQs. Okay, so thank you for joining me, guys.